Good morning, everybody. Thank you, Dr. Lalit, Dr. Tinku, and Novartis for this opportunity. So, as we're talking about evolving anti-VEGF, I think, can I have my slides, please? Yeah. So, as we talk about evolving anti-VEGFs, I think it is important that we go back to where we started, and it is always going back to the roots. So, a few of the slides have been provided to me by Novartis, so that is a disclaimer, and this is a disclaimer by Novartis as well. So coming to, taking you back to time when 2006, probably I was still in my, I'd finished my post-graduation. So, and I think many over here were probably not there as well. So in 2006, all I remember was there was the era where there was laser photocoagulation, which was even being used for DME as well as for AMD. And I remember the time when, the only thing that we knew about AMD was that if you find a hot spot, you laser it. And visual acuity gain was not something that was talked about during those times, and it was only when the first molecule came in, which was Ranibizumab in 2006, which with their Marina and Anchor trial, and the difference in visual acuity gain that it made basically changed the paradigm or the way that we were seeing these diseases, where treating the disease is one thing, but getting visual gain out of it and talking about alphabet gain and line letter gain was something that came into purview. Since then, obviously, anti-VEGFs have changed the way that we look at diseases now. It's really reduced, the role of reduction in the preventable blindness all over the globe. So, but where does Ranibizumab stay, or where does it stand today? So this was the first innovator molecule. It was the first molecule. I think we proudly, all of us have used this molecule and grown with it. But then there are a few points which we could discuss today, and which also brings us. The music is not from my side. So this was the first molecule, and then when we talk about the evidence and efficacy, we talk about the innovator edge and the pharmacoeconomics, and these 3 points are something that kind of needs to be discussed when we talk about an innovator molecule and we go through the journey of anti-VEGFs in the world. So coming to the
AV people, can you please help? ये तो आवाज बहुत आ रही है.
So first we come to.
Speaking.
So when we talk about the original molecule, I think this is the only molecule which has the maximum number of indications, and it has the maximum number of trials that are there, and the biggest thing is the maximum number of real world evidence. And what it basically supports is also the trials and the usage and the evidence that we have for over 730,000 patients all over the world. So coming to, there were some landmark trials which were done with Ranibizumab, the original molecule, where, it kind of obviously was better than Bevacizumab in studies, whereas it was also comparable to the newer anti-VEGF, which was Aflibercept. The rival study also told us the safety profile of the molecule, along with, Aflibercept, and also about the similar number of injections. So if you talk about pharmacoeconomics, then obviously with similar number of injections with a costlier molecule and this molecule in today's world would probably make a difference. The similar kind of evidence was also seen in the treatment of DME, where anti-VEGFs along with prompt laser or deferred laser, whereas anti-VEGFs played a very major role. And I remember during those olden days where central involving and non-central involving DME was the talk. And we used to always talk about, okay, whether you give the laser burn here or you don't give the laser burn here, or you see a scotoma or you don't see a scotoma. Whereas with the advent of anti-VEGFs, we kind of started talking about letter gains and how many line gains are we going to get. So similar was the story with RVO, and Ranibizumab has had its bold print as far as treating RVO is concerned. So now we come to the Luminous trial, which was basically real-world evidence. So we've all used Eccentrix or Lucentis over the years, and this was the biggest trial, which basically was over 42 countries with 30,000 patients involved in 488 sites. And it was amazing to see that the injection was working and worked very well across all diseases that we know of, where we would use an anti-VEGF molecule. And this was not only the early gains, whereas the long-term arms of these studies also showed that this was persistent gain that was seen over the long term. Now coming to the innovator edge, this was, we call this innovator not just because it was the first molecule, but there is a difference. So now that we have biosimilars, and this is something that is very important for us clinicians as well to know, that when we talk about an innovator molecule, the difference is basically that the molecule has to undergo clearances for each and every step of clearing a molecule. Whereas when we talk about a biosimilar, it is a single process of clearing where all these properties, the clinical studies, pharmacological, non-clinical studies, and the analytical data is characterized into a single club, and then the molecule is kind of, is approved for use. So it is basically a totality of evidence, and not the single step process of clearing. So if an innovator molecule fails even one single step, that molecule is not taken into consideration. Whereas in a biosimilar, that is not the true case. So when I say that, and the other problem is that biosimilar, the approval process is not fixed globally. If you see, there are different biosimilars all over the world, and they all have different ways of clearing in their respective countries. And why this information is important is because we are going to be faced for further molecules which are biosimilars. So ultimately, having that innovator edge does help. Now, the second question is that whether these biosimilars are also interchangeable. When I talk about interchangeability, is that these molecules can be substituted without a separate prescription, or it can be substituted for a particular condition without any difference in any of the quality characters. So there is only one insulin drug in the world which is actually interchangeable. Other than that, none of these molecules are frankly interchangeable. So this is one important point, and especially this point is important with newer biosimilars which are coming in the world now. So coming to pharmacoeconomics, this was an optimized calculator by Novartis, which again compared, basically if you compared a Ranibizumab biosimilar to the original molecule, I think the costing is pretty much almost the same over the years. So coming to a few examples, this was a patient with a 618 N18 vision with this kind of a CNVM and fluid and cystic spaces. And in 3 loading doses, the patient recovered very well with eccentrics. We went ahead to do a multimodal imaging at that time and just acquired the OCTA, and you see this network over there. The patient continued with treat and extend treatment, and this is now a follow-up almost 7 or 8 years, and the patient is doing well only on eccentrics. This was a second case, a 74-year-old male, again with a hotspot on the ICG and a very nice network on the Octa. And this case, I probably would not have used eccentrics, but the patient chose eccentric at that time because of financial restraints and also clearances that they have. And the patient is 6'6" today with that kind of an OCT. I don't know how, but. And this is a case of chronic DME. I think in these kind of cases, I think Ozurdex would probably be one, or if this patient was not responding, I would have probably given a Pagenex for that matter, or even an Eylea. But for whatever constraints, again, the patient was given eccentrics because he chose to take eccentrics because he was shifted through many molecules at other places. But he said that no, there was a time when Lucentis I used to get and I used to get better. So Lucentis was given, and then we got a Vio effect, even in this day and age of very good molecules in the country. This was again a lasered RVO. This patient was again under some scheme, and then this again is kind of a chronic DME. The probably RVO where you probably would not use an innovator molecule or Lucentis or eccentrics with newer this thing. But then finally with this patient also chose eccentrics and kind of improved immediately with 1 or 2 injections. So I would probably just say that yes, we have gone through the line, but then the innovator molecule still holds their chance. It still holds their value today in the market. There are a numerous number of examples which can be taken out, and we all have a lot of robust data to kind of support this, that the risk-benefit ratio of a molecule, innovator molecule, still holds true with the backing of the studies that they have. We know of all the complications. We know we ourselves have a lot of real-world evidence with us. And so probably over the last 18 years with long-term data, I think it is still a robust molecule and could be used in our armamentarium. I think interchangeability is one aspect that kind of has been brought out, especially when I read through this presentation as well, and which kind of makes me think with newer biosimilars coming into the market, where we stand with innovator molecules. and also the the biosimilar changeability. When we talk about international data and we talk about biosimilars international data, I think the process of approval is very different from what every country is following. So I don't know whether it is right to just take that data and kind of put it across the board with thinking about whether we are going to get the similar results. And I think it's important that as kind of Novartis has put their data across through over us, I think we also have the responsibility of standardizing data assessment and acquisition for our real world evidence through these molecules over the years. Thank you.
Thank you, Gagan. Let's have some discussion on this topic itself. So for you, you still don't believe in silver or platinum. Old is gold for you?
No, old is gold because old is gold.
Old is gold?
Because old is gold, but...
no, let's be very honest. Do you think that biosimilars don't work? Or?
No, I believe, sir, I believe that all molecules work. It's not that all molecules don't work. This topic was basically intended, or this talk is basically intended to the way that that there is innovator edge that is there. I think
Do you use biosimilars in your practice?
A lot.
A lot.
A lot.
So what is the edge which original molecule has?
Sir, original molecule I believe has, I don't believe that there is a very huge difference between actually the real world evidence or data that I have between biosimilars and the original molecule. But if you talk about trust and when you discuss with the patient.
The whole world is moving towards biosimilars.
Yes.
Why are you wanting to retrace it back?
It is retrace it back to a certain select
The reason
cases.
I'm asking is because even US, Western countries, they have approved so many biosimilars. India was the first biosimilar country in the world. So old is gold. I agree. कहावत के लिए तो अच्छा है. Old is gold, but it has to have an edge. You see, apart from raising doubts about those studies which you have shown reverse pyramid and Sida pyramid. But that is what DCGI wants. Actually, that's not that the biosimilar industry is not working in that direction. That's what they want.
No, biosimilar industry is working very, very well. I don't believe that biosimilar industry is not working. But what I basically intend to say is that I'm not at all against biosimilars, and rather I think a large part of my practice is on biosimilars and not on Eccentrix or Lucentis anymore. But I think the idea of this session was to take you through the history of Lucentis. And today also, I think probably during a discussion with the patient, probably, the trust issue with the innovator molecule does come in at times.
That is the single most important fact that you said that, lot of trials, lot of studies, lot of real world data, maximum number of patients, what you said, 73 lakhs or whatever patients have been testimony to the fact of its working. In case you want, I don't know whether once you are wanting your eye, you would maybe prefer a innovator molecule.
So
my eye, I would definitely prefer the newer molecule.
Yes,
so I think it's not the biosimilars, it's the influx of a plethora of biosimilars that are coming in. And most of them, some of them over the years have had a number of studies, but the newer molecules, the newer biosimilars that are coming have very short-term studies. They don't have enough patients, or they don't have enough data or enough, long-term results. So that is where we have to hold our hands. With the newer biomoleculars, till we have very robust data, I think I would hold my hand in using every new biosimilar that comes into the market, and there's a glut of them now coming in.
I agree with this point because all of us practice real world data or evidence-based medicine. The more the longevity of that drug, the more the people have practiced and the more publications are there on that. So you tend to have more faith or belief in that. But this may be the safest. I agree with you. A lot of my patients still tell me, Dr. Sahab, wo Lucentis aap laga do.
Agreed. And I also come across, a very practical thing, but a lot of government schemes are going in with biosimilars, and I don't find anything wrong in that. I have wonderful results with a lot of biosimilars.
How do you tackle this situation? Maybe Vikram, everybody
can
answer.
I wanted to make one point regarding your question, that you said, what is the edge? So only edge that we also find now, that so we have had one patient who had Avastin, many Avastins before. She got one eye injected with Avastin. She got some complications with Avastin. So that was in 2016-17. So then other eye also she has. Then she was getting Eylea, and then in between she got inflammation with Eylea. And now her disease was again active, and this was the only seeing eye. And we trusted on Eccentrix, so discussed with patient. And I think that is the best edge, that it is still the safest. So we've not had, and now we have shifted her to eccentrics.
No, what I was wanting to know from Vikram and Ramesh and other people is, you see, I have had not one but multiple times this issue, because we started Lucentis in this country long time back. Patient comes to you, Doctor Sahab, mujhe Lucentis laga de, to wo laga de, not this, and he gets approval for say any biosimilar. How do you tackle this situation? They will ask you pointedly, sir, Doctor Sahab, same ही molecule hai ya different hai? So I am facing challenges that because he actually brought from his dispensary.
So I get your point, sir, that it is sometimes difficult to convince the patient, but I think that is where we do say that now it's, of course, it's an Indian drug. Whatever biosimilars that we have right now, most of them are Indians. So we do say that, and now it has been almost 7-8 years, more than that almost, and it also has a good track record. So I think that is the only answer
Ramesh,
for that.
you have had any patient where there is a patient of RV or any disease, he is not responding to biosimilar but has responded to innovator. Same molecule, Ranibizumab, biosimilar Ranibizumab. Mike, can you put on the mic? AV.
Efficacy-wise, it doesn't change too much, to be very frank. What doesn't work?
Safety. It's the
Safety is
issue.
the issue, and second is the FDA approval. Where when we start talking about convincing the patient, when the patient asks you, I want a Lucentis and I don't want a biosimilar, then probably the way I explain is, you can have a shoes from a local market, you can have a shoes from a branded company as well. And that is the edge where you have. You can have the effect, the way it works, everything is well proven, well analyzed, and that is where probably Lucentis is much better than the other.
This is the biggest marketing point I think Ramesh has, that if you tell a patient this is a whatever branded or local or whatever, patient, in fact if I am the patient, we will go towards that, unless there is a huge cost difference. And today, thanks to the innovator molecule, the cost difference is not much at all. Not much at all.
Exactly.
So I think Gagan also raised that point of chart.
I think because I personally feel that there's a different categories of patients. There is one category which wants the best, and they just want the best. So they're not bothered about what you're giving, but they want the best. Then there's a second category which are going to just take what they're given. And then there is a third category who are always going behind this thing that, Docs Saab, which is the most safest, which is the most studied molecule? Aapne kitna sabse zyada diya? Those kind of questions come in. And that is where probably Lucentis still is probably the only drug which holds.
Yeah, Tinku, you want to add something?
Gagan, you showed cases where the patient himself chose to get Lucentis. So what are the indications in today's times that you would choose, eccentrics on your own rather than the
DME is something as a primary drug I would not choose, and I would choose Lucentis over any other molecule, probably to eccentrics, in DME. AMD, frankly, probably not as a primary treatment if I was to choose that, and especially because I still go back to the gold standard ways of doing an FFA, ICG and OCTA today, and I don't think that I would use Lucentis, frankly, as the first line. But yeah, DME, I would not, I would not mind using as the first line of Lucentis.
Anybody else, any point, please? Any from the audience? How do you choose innovator versus? Yeah. You can have a roving mic. Yeah.
I think patients don't understand. Most of the patients don't understand.
Mic दे दो.
Mic, please.
Mic को on ही रखो ना, बार-बार off नहीं.
I think that most of the patients don't understand what innovator molecule is. The age, I think, is the cost, number one, and number two, the difference between imported and Indian. That's all.
I agree, because you see, it's a marketing gimmick nowadays. You see, you tell any patient that ये imported है और ये local है, so immediately वहाँ जाता है. दूसरा cost issue आ जाता है. And third, very important thing which Ramesh told us is safety concern. Although everything is safe with biosimilar also, but if you have an edge, because the key word what Gagan told, edge, their tilt towards innovative will definitely be there.
Sir, I am from Medical College Patiala, where I deal with the not well-to-do people, poor family people. And I have never used the Lucentis. I am using Zydus company, and I am getting the excellent results.
Yeah, yeah. You see, there's,
I'm getting
I
excellent
agree.
results.
I agree. You see, the point of discussion was not that Avastin does not give or Zydus does not give results. Results are there in, you are
I'm
using
giving
Zydus.
Ranibizumab.
Here, Ranibizumab. That's what I was, why I caught him was about the biosimilar. So many biosimilars are, and everybody is using. You see, if you see his patient sheet also, majority will be biosimilar.
Yeah.
There's no doubt about that. So, but these points are worth debating. I will point you directly. Suppose मेरी आंख में लगाना आपको तो आप लगाने वाली वो होनी चाहिए जैसे सर आप ये लगवा लो आप बात वो वाली बात आ जाती है because of the wealth of data, because of these 73 lakh patients have been given, and because of so-called safety issue. Cost is not a consideration today because believe me, cost comes secondary. Cost becomes secondary. अगर मेरी आंख में फ़ायदा हो जाता है ना किसी वहाँ से तो I'll hook or by crook get that molecule. So safety is of prime concern. And costing of, thanks to so many schemes floating by every company, cost is not much difference at all.
It is not a difference at all now.
So thanks Gagan for
Thank you.
exciting this useful debate about innovator versus biosimilar. And I still believe your statement that old is still gold till the time platinum comes. Sona to sona rahega. And because of the wealth of data, because of trust factor of safety, and cost not being much of a consideration.